So welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Executive Committee. Today's meeting is officially called to order. Please note for the record that Dr. Michelle Morse is representing Dr. Ashwin Vasan and Erin Kelly is representing Deputy Mayor Ann Williams Eisen, both in a voting capacity. Also, according to Section 14 of the bylaws, committee attendance, if any member of a standing or special committee of the board will not be present at a scheduled committee meeting, the member may ask the chair of the board to request that another board member, not a member of that committee, attend the scheduled meeting and be counted as a member for purposes of quorum and voting. So for the record, Frida Juan has delegated Sally Hernandez Piñero to be counted as a member for the purposes of quorum and voting in her place. So next on the agenda is the adoption of the minutes of the board meeting held November 17th, 2022. Are there any questions, comments, or suggested changes? So can I hear a motion to accept the minutes?
So moved.
All in favor, please say yes.
Yes.
Opposed, say no. So minutes adopted. So during the executive session, the board received and approved oral and written governing body submissions from NYC Health and Hospitals Bellevue. The board received and approved semi-annual governing body reports, written submissions from NYC Health and Hospitals Jacobi and North Central Bronx. So let me move on. So thank you, Dr. Marthone, Fenioski Peñamora, also Dr. Michael McRae. They visited the Asylum Center at the Grove Hotel November 21st. So Dr. Peñamora, would you like to provide any feedback on that visit?
Yes,
Comments for the Grove Hotel visit?
Oh, yeah, no, sorry, I was thinking, reading something. I thought it was really impressive, the activities that is happening there. We saw how the different kind of individuals that are there are able to get the services that they need. We visited some of the offices that are providing services for younger children that need to go to school, and that they were actually talking to the Department of Education. We also saw, some of the facilities in terms of the where they sleep, and everything looked incredibly well kind of managed and really very supportive environment. So we were very impressed when we visited.
Thank you for your report on the visit. So let me move on to Vendex approvals. Since we began the process of approving contracts prior to Vendex approvals, there is one item on today's agenda requiring Vendex approval, and that approval is currently pending. There are two items from previous board meetings pending Vendex approval. Since we last met, no approvals were received. So we will continue to notify the board as outstanding Vendex approvals are received. Move on to the president's report. Let's move to the resolutions. I'm sorry. So item number 3 on your agenda, which is amending the resolution adopted May 25th, 2022 by the Board of Directors of New York City Health and Hospitals Corporation, authorizing the funding through December 31st, 2023 of an affiliation agreement with the State University of New York Health Science Center at Brooklyn, aka Downstate Health Sciences University, for services at NYC Health and Hospitals Kings County and NYC Health and Hospitals South Brooklyn Health, formerly known as Coney Island, to extend such funding through June 30th, 2024 for a total cost not to exceed of $12,221,174, which includes a 10% contingency, and this is being presented directly to the executive committee of the board today. So, welcome.
Good afternoon. Nice to see everybody. Yes, we're here to ask for another 6-month extension. The reason why the dates run through June 30th of 2024 is because we have an obligation to SUNY to provide a 1 year's notice. So we're always kind of running 1 year ahead. But nonetheless, we feel like we've made some really good progress with our partners at SUNY. We basically have the framework of a deal that we were hoping that we could have actually had a little bit more time to present that here to you today. But we decided together with SUNY that we would just ask for this 6-month extension. I'll say that, the terms of the extension is being signed with SUNY. It's a negotiated acquisition that SUNY is especially, well-positioned to, serve us well. I think we can talk a little bit about the relationship, that we have, with them. But again, we certainly want to continue that relationship. On the next slide, the reasons for the extension, and it's because we have this 1-year notice provision, and that's why the dates extend through 2023. The current agreement between us and SUNY, expires on, the 23rd. The 6-month extension, will allow us to get ourselves through the period of June. And down below, we just note with King's Hospital, the services are emergency medicine, psychiatry, and radiology. And at South Brooklyn, it's surgery services. Next slide just shows you the history of our financial relationship and the periods of the previous agreements. You can see there the extension at the very bottom, extension for the second half of FY24, which runs according to the contract schedule, January 24 through June of 24. So that's the 6-month extension. On the next slide, we're showing just the history of the dollars in terms of the relationship that we've had, with SUNY. I think importantly, the extension period is really $11.1 million with, as mentioned, a 10% contingency for $12.2 million. It's just a straight extension of the dollars. We pretty much, spend at this rate. So there's nothing new or changed for the 6-month period. And then on the next slide, we break that out, right? We show how much we're spending at South Brooklyn versus at King's with 10% contingency and the not to exceed amount of $12.2 million. So we will not we will not even more than likely see any reason to even dip into the 10% contingency, but we will report back on our expenditures here. Any
I've
questions?
lost track of SUNY, because we've done multiple extensions, and I guess with the other affiliates, we did it for a block of time, 4 years, 5 years. Are we still in the process of developing that longer multi-year agreement with them? Is that?
Yes. We're expecting, I'm Joanna Wiener, I work with
Hi,
Nancy.
Joanna.
Yes, we are expecting to have in place a longer term agreement that will be effective July 1st of 2023.
2023,
Yes.
okay.
Even though we're asking through 24, we have to, because SUNY has
That 1
an
year.
arrangement in their union with their physicians where they're required to give a year's notice, so it makes them more comfortable for us to have that authorization.
Or because of that as well.
That's
We have that
why
one
we ask always for a year in advance.
year. Right. Right.
So yes, we expect our relationship with SUNY has evolved to have a little bit less of a clinical presence, but a really robust academic presence. And so we're reconfiguring our relationship to reflect that evolution. And it's just taken a little bit longer than we had hoped to figure out the finances, but we're pretty much there. But figured we should just start on an academic and fiscal year, the whole process of the longer term arrangement.
Okay, thank you.
Actually, if I can just introduce, did you introduce yourself, Joanna? Joanna Wiener, Senior Counsel in OLA, outstanding member of my team.
Sheldon, is there something you would like to add to the presentation?
No,
Or?
just to support what Joanna just said, the biggest impact would be if we did not do this a year in advance to our radiology space, because they would have to be put on notice for a year, and some of our physicians would opt to leave, leaving us in a position where we could not provide optimal services for our patients. So that's why it's imperative to do this going forward.
Thank you for the extra information. No, sorry. Okay, so,
Congratulations, Sheldon, on your award.
so let's have a vote then. All in favor, please say yes.
Yes.
Opposed, say no. So the resolution is approved. Thank you so much.
Yes.
Peñamora, you go next, number 4.
Thank you. Authorizing the New York City Health and Hospitals Corporation, the system, to execute a 5-year revocable license agreement with the New York City Police Department, the licensee, for its continued use and occupancy of 75 square feet of space on the roof of the main building at Elmhurst Hospital Center, Elmhurst, and 50 square feet of space on the roof of the end building at Queens Hospital Center, Queens, to operate radio communications equipment with the occupancy fee waived. This was presented at the December 5th Capital Committee and was approved for full consideration by the board.
Good afternoon. Thank you. I'm Menji Indar, Assistant Vice President, Office of Facilities Development, and here with my colleague, Mr. Berman from OLA. Unfortunately, Leora John Teff, who presented this to the committee, is not feeling well, so we're going to present on her behalf. So these are antennas that have been at Queens and Elmhurst, part of NYPD's communication equipment since 2012. This is part of NYPD's 911 response network. The equipment does not compromise facility operations, nor does it pose any health risks to our staff or patients. Next slide. So the NYPD will continue to have occupancy of 75 square feet of space on both Elmhurst and Queens, 50 square feet of space at Queens. Both of these agreements were previously approved by the board in 2015 and 2017. There are no occupancy fees. They're waived from the NYPD, and the agreement will commence on February 1st of next year. And the next slide is the resolution. Happy to take any questions.
Thank you so much. Any questions? Okay, hearing none, then all in favor of the resolution, please say yes.
Yes.
Opposed, say no. Resolution approved. Thank you so much. Next one is
The next resolution is another set of antenna licenses. This one is for 2 different antenna licenses.
let me get a. Do you read that already?
Yeah, I haven't read it.
Let's have Dr. Peñamora read it first, and then.
Thank you, Jeremy. Authorizing New York City Health and Hospital Corporation, the system, to execute a 5-year revocable license agreement with Spring Spectrum Realty Company, LLC, the licensee, to operate a cellular communication system in approximately 300 square feet of space on the roof of New York City Health and Hospital Lincoln, the facility, at an annual occupancy fee of approximately $362 per square foot, or $108,604 per year, to be escalated by 3% per year for a 5-year total of $576,595. This was presented at the Capital Committee on December 5th and was approved for the consideration of the full board.
Go ahead, Jerry.
So yes, another antenna license agreement. So this one is a commercial one with Sprint for the space on the roof of Lincoln Hospital. This is again a renewal of a previous license that was approved by the board 5 years ago. And as with the NYPD license, there's no interference with the hospital equipment from the operation of this antenna. It doesn't compromise the health of our patients. The current license is due to expire on December 30 of this year, so shortly. The new agreement will basically continue the prior arrangement, but with the bump up of 3% of the rent, so that Sprint will pay us $108,604 per year. And over the 5-year term, each year will be increased by 3%. Any questions?
Any questions? Okay, all in favor, please say yes.
Yes.
Opposed, say no. Resolution passes. Thank you so much.
I
So,
recuse myself.
Mr. Peñamora has recused himself from the next one, and I will read that one into the record. Number 6 in the agenda, authorizing New York City Health and Hospitals Corporation, the system, to further increase the funding by $6,409,289 for its previously executed agreement with Array Architects, Inc. for architectural engineering services for the renovation of space at NYC Health and Hospital's Bellevue Hospital and NYC Health and Hospital's Woodhull Hospital over a 5-year term in connection with the system's correctional health services initiative to treat its patients who require higher levels of care in its outposted therapeutic housing units, which follows a previous funding increase of $1,814,880 authorized in November 2021, such that the funding is increased from $10,477,880 to $16,887,169, including a 10% contingency of $1,535,197. And this was presented to the Capital Committee on December 5th, 2022.
Good afternoon. My name is Manny Saez. I am Senior Vice President for the Office of Facilities Development, and I'm here with colleagues Patsy Yang, Senior Vice President for Correctional Health Services, Oscar Gonzalez, Senior Assistant Vice President for the Office of Facilities Development, Lou Mendez, Senior Director of the Office of Facilities Development, and Denisha Simpson-Franklin, Senior Director of Correctional Health Services. This presentation is an increased funding for the OTXHU project associated with the SCOC changes with Array, and I hand that over to Ms. Patsy Yang.
Yeah, sorry, this is very quick. I think the board members are familiar with this project. We're requesting approval for additional support to accommodate some design changes that were requested by the security agencies, both at the city and at the state level. The Bellevue and Woodhull projects would bring online about 256 beds for some of our most clinically fragile people, patients who are currently in the jails on Rikers Island. The population continues to grow, as does the morbidity, the level of disease and clinical needs of our population. So these beds become more critical in our view. Thank you for your support.
Okay, thank you, Patsy. Good afternoon. My name is Oscar Gonzalez, Senior Assistant Vice President, and I will jump into the background and some of the history on the on the project on OTXHU. So the project was publicly announced in 2019. We immediately pivoted and began the procurement and the design and services of our consultants, our designers, and our program managers. Specifically, Array was performing the design for both Bellevue and Woodhull. We also included AECOM to do the program management for both locations as well, and we procured E4H to do the design services only for the enabling portion of Woodhull. We proceeded ahead, continued with the designs, then we procured the contractors, the builders. By November 21st, we brought in both contracts to the board to get board approval for Consigli at Bellevue and for Gemco at Woodhull just for the enabling work. And that was, and the second part was in March 2022. Then we came back to the board for an amendment on November 2021 to accelerate the project, to bring it in on time. Just after that, as we're trying to lock in the price with Consigli as part of the regulatory requirement to get SCOC approvals, we locked in. We were able to include the changes. We asked Array to make the changes. We included the changes, and we were able to lock in the price for Consigli. So we brought the Consigli amendment back to the board, and we did receive approval for that. But we did not come back to the board to get an amendment for Array because of the anticipated changes that we would have at the Woodhull location. So in January 2022, the SCOC required additional changes at the Bellevue location, as I mentioned, for additional outdoor recreational space and patient and staff flow and program LoRa plan. And on March 29th, SCOC provided approval for the Bellevue project, which integrated SCOC changes as requested. And then we adapted those those changes to the Woodhull location, but we have not run through that regulatory process just yet. In addition to that, we did not request for contingency for the designer from the onset. So we're also seeking for that increase in value. This SCOC change is separate than the DOC changes, so we're still in the progress of getting those regulatory approvals. So we We'll see, what comes about from that, but that'll be forthcoming. The next slide shows essentially our hierarchy. You have health and hospitals on top, then you have AECOM, our program manager, then you have Array, which is highlighted in orange. They are our designer at both locations. In the middle, you have the decanting consultants and contractors, and on the right, you have Consigli doing the work at the Bellevue location. The next slide shows you the scopes of work. On the right side, you have the base scope of work, which is the additional beds, the upgrades of mechanical, electrical, and plumbing systems, including the environmentals and for patients and staff. And on the left, on the bottom side, you'll notice that there's a new exterior elevator, recreational space for the SCOC. Originally, it was going to be on the roof. Now we're putting it over the emergency department. So that particular change was as a result of having the entire facility or the entire experience of when the patient gets dropped off and into the area to be completely secure. So by having the recreational space on top of the building, it was going to have a big impact on the facility. So that's why we went with this alternate location. The next slide shows you the adapted changes. So what we learned from Bellevue, we adapted it at Woodhall. So on the right, you have the base program, and on the left, you'll notice there's a new van access, there's a new sally port, there's a new 3-stop elevator from the 9th to 10th floor and into the roof. So there's the outdoor recreational area, the 10th floor roof replacement, and a new curtain wall that's also getting replaced. Again, this is all to have that secure experience of dropping the patient off and having a secure facility while they're there. The next slide shows you the progress to date. So originally we had an approval for not to exceed for $8,663,000, and we came back and received an approval to increase the NTE, the not to exceed, by $1,814,880, and we increased it to $10,477,880. The SCOC design changes at Bellevue were finalized. The construction of Bellevue is scheduled for completion on 2023. The Woodhall builder RFP is currently released, and we're pre-qualifying vendors at the moment. The schedule for Woodhall is expected to complete in 2024, and Array is doing a tremendous job so far. So they're doing really good job for us. So the official request is for us to increase Array's contract by $6,409,289 to a total not to exceed value of $16,887,169. And when you break it up, specifically for Bellevue SCOC design changes, that value is $2,389,708. And for the Woodhall adapted design changes, that's $2,484,384, plus the 10% design contingency that we did not originally request, and that value is $1,535,197. All these costs are within our project budget, so we're not seeking for any additional budget at this time. And the contingencies have all been approved, or they're in the progress of being approved by OMB. And we will, there's one more slide. The MWBE utilization plan, originally the utilization was 36.47%. When we came back and we requested for the first not to exceed for the acceleration, it dropped the utilization to 33.1%. However, with these changes and with the additional design contingency, we're increasing the utilization back up to 34%. And for today, 50.64% of Array's invoices to date include the MWBs. And we'll take any questions.
Any questions? Sally?
It's more a comment than a question. I have the same objections I had to the delays in Bellevue. Bellevue is 5 or 6 months. This is how long?
About that.
It hasn't even been finalized yet, right? We're still
Correct.
in the process of approval.
Correct.
And it's all because of some ridiculous fear that this very vulnerable population poses some kind of public risk. And it's not for commentary, it's just my perception that it was a waste of time and money. And it's unfortunate that we have to comply with their wishes.
Thank you. Any questions? Any other questions, comments? Okay, hearing none, then let's, may I ask for a vote? Then all in favor of the resolution, please say yes.
Yes.
Opposed, say no. Resolution approved. Thank you so much.
Thank you.
Thank you.
Thank you.
Starting on respiratory illnesses on the rise, which are even evident in the challenge of getting a quorum today. And we have several members of our own senior staff who are out sick with a variety of respiratory illnesses. Definitely not all COVID, although at the moment, COVID numbers and flu numbers are going up. RSV has been going down, but don't count on that staying that way. Still very early in the winter. Well, actually, I guess technically not even yet in the winter. So we're again trying to get people to vaccinate, to wear masks when they're inside, to go for testing whenever possible. The mayor announced a new comprehensive plan to do more to help unsheltered people with serious mental illness. And I don't want to go through it all, but what I want to say is that there has been a lot of misunderstanding about what the mayor has said. The mayor has not said, as I continue to read, that people should be hospitalized against their will. The change that the mayor has asked for, and which I very much support, is both subtle and powerful. What the mayor has said is that when somebody is unhoused and they are suffering from severe mental illness and they are of harm to themselves or to others, they should be brought for medical care. The challenge, the change that I think is subtle and profound is that that does not require that they are saying that they are going to imminently kill themselves. They're not necessarily saying that they are going to imminently hurt someone else. They are not necessarily running into traffic. Under those circumstances, they always would have been brought to the hospital. What the mayor is saying, and what is supported by the case law of these two existing state laws, 938 and 941, is that people can be brought in on the judgment of either a police officer under 941 or a mental health clinician under 938 if they appear to have a serious mental illness and that they are of harm to themselves or to others. And really the way I hear it and the reason I support it is that what with the mayor's heart really is don't walk by. I mean, what does it say about, society that somebody is lying stretched out, on a subway platform, clearly in psychosis, inappropriately dressed, a wound that's unhealed, no plan on how they're going to get their food or shelter, refusing voluntary services, because that's always the right answer, is to offer voluntary services. And if you judge them, well, they're not of harm to themselves because they're not going to kill themselves, so we're just going to walk by. It doesn't seem to me right. It doesn't seem to me common sense. It doesn't seem to me what a just society would do. And that, I understand nobody favors they're criminalizing this. Nobody wants anyone arrested. Nobody wants anybody to go to Rikers. No, all that the mayor is saying is that the case law does not support the idea that you would just ignore them simply because they don't say that they're about to kill themselves, and that clinicians can use good judgment in determining whether or not someone is of harm to themselves. So I've been trying as much as I can. It's a complicated issue, and people are entitled to their views of it. But what I most want to do is to counter what I view as a simple untruth that the mayor has said we should be involuntarily hospitalizing people because they're homeless and mentally ill, because he's never said that and he doesn't think that, and we wouldn't support that. So I do think providing care is very valuable. I wanted to mention under nursing excellence that we had 2 of our hospitals now have reached the level of pathway to excellence. The first one was Kings County, and now our South Brooklyn Hospital has joined it as well. It's really a standard when you look at it that's all about empowering nurses. And I think that's so important because we can all learn skills, but if people are empowered, they'll always do the right thing, regardless of what the circumstances. Gotham had a very impressive survey with a rating of 96% and received a variety of awards, which I've put into your report. One of the things that I love about my job is that the president's report for Colicia, I think, received it at 11:15 p.m. Christy and I were both, of course, on email, but it's already out of date, right? So it's out of date because at the time that we wrote it, we did not know whether or not there would be a continuing resolution on the budget. And last night, the House passed a continuing resolution extending to December 23rd to allow for additional negotiating time. And it's expected that the Senate will likely pass it today. And perhaps that's out of date if someone already knows that the Senate has already passed it. But no one has told me that, so I'm going to go that it has not yet happened. I want to read to you because it's important as part of our transparency, the contracts that Mayor Adams issued an executive order on October 7th, 2022, allowing the city to expedite its procurement processes to timely meet the needs of the continued influx of asylum seekers. We very much appreciate, Dr. Peña-Mora, that you went out there with your colleagues. People really, when board members go out, it means so much to staff members. We've been an integral part of the city's response in providing support for the arriving immigrants, and I've authorized limited emergency contracting to support such efforts. I've authorized the following new contract actions: a contract to provide food services to the asylum seekers housed at hotels with LICCOM for LLC for an amount not to exceed $8,500,000 for a period of 6 months, and a contract with an additional hotel, the Stewart Hotel, for an amount not to exceed $27,862,000 for a period of 6 months. And so with that, Mr. Chair, I want to thank you. I want to thank, say how lucky I am to have such an amazing board supporting me in health and hospitals. I have amazing staff members. Colicia keeps us all, together, including today when we had, quite the challenge. And I'm deeply grateful to all of you, and I wish you all a very happy, healthy new year. Thank you.
I just had a question.
Please.
Mitch, what is our capacity for taking in folks as part of the mayor's homeless initiative?
So I'm glad you raised that, Sally, because it's come up. I believe that the group of people that we're talking about is actually very small relative to our size. I mean, and we've been very open that we have workforce challenges. We would gladly open more mental health beds right now if we could identify a sufficient number of clinicians. That being said, our job will always be to triage people. And this is a relatively small number of people. There are 50 hospitals in New York City. We believe that there are 1,000 mentally ill people who are unhoused in New York City. And only a small part of that 1,000 would be people who are refusing voluntary services and are of harm to themselves, right? So it isn't, people are conflating the number of mentally ill, which is much larger, the number of homeless, much larger, But when you get down to this group, it's fairly small. But their use of services actually causes a huge amount of churn through the system because they're so hard to take care of because they're not in the right place or receiving the right treatment. The other thing that's interesting to those of us who watch how government works, part of with the mayor's push to this, the state came forward with 50 more beds and a promise of 200 more that they would do. And we've already done placements. They'll do longer stay people. So people will come to health and hospitals or another hospital with an emergency room, be evaluated, maybe have a 10, 14-day stay. But then if they need longer treatment, instead of staying with us, they'll move to a state hospital. And then also this week, Greater New York committed that they would open up more beds, right? Because they saw that people heard what the mayor was saying and that the people agree, people need help. Also worth mentioning, often people who refuse treatment, if you actually get them out of that incredible stressful moment in the subway where they're saying, no, I know, you get them to a safe place and you feed them, and there are kind people, some of them actually then take voluntary treatment. So it's not even as if just because somebody is in that state, when you meet them, that it's impossible that you couldn't get them in a 12-hour stay to agree to a daily, hospitalization program, a case manager, a safe haven bed. So I sort of see it as a typical and kind of thing, but not a but sort of thing. We need more beds. We want to open more beds. We're opening them as quickly as we can find staffing, but that shouldn't preclude us. It shouldn't enable us to just walk by that person. We should still bring them forward, see what we can do, try to make their life better.
It's like the homeless who come to our show vans.
Right.
I mean, it's the same relationship that develops and allows for care.
Yes. And again, when you're taking care of someone, especially in psychosis, you don't know what they think you're trying to do, right? Or what horrible idea they have in their head about what's going to happen. And that's why an involuntary movement can be difficult. But then when they're in a hospital and the people around them are doctors and nurses and asking them how they are and providing food, right? Often people's views change, right? Because the thing that they were so worried about isn't actually happening. But how would they know that while they're lying there in the subway station? How would they know that you wouldn't be, trying to medicate them against their will, which is a different court order, right? Or that you weren't trying to, lock them away. So my hope is that, this helps to bring everybody more in the middle and more focused on the person. What does the person really need?
Thank you.
I have a follow-up question. What is the procedure if the police identify that individual? They take it to one of our hospital or the closest hospital to the place that they are picking up the person?
So that's a little bit gray. In general, all ambulances go to the nearest hospital. That being said, either the hospital, the ambulance crew, or the medical director for the ambulance service can make a determination that the person would be better served in a different place. And if that place is a reasonable distance, they can be brought to that place. So, and this is true of all things. If someone calls an ambulance and they say, well, the nearest hospital is X, but I always get my care at Y, and Y is within a reasonable distance, the ambulance will take them to Y. So it's supposed to be a closest ambulance closest destination unless there is a good reason. And so we've been trying to, and you can see how this too has two sides to it. On one hand, we as health and hospitals, we like the idea of people being brought to us because we're not under economic incentives. We see this as our mission. I feel my staff really welcome these patients. On the other hand, I do want the other hospitals to do the right thing as well. And there are 50 hospitals in the city. We represent 10, but we represent 55% of the mental health care, 20% of the medical, and 55% of the mental health, which shows how much is mission driven, right? The other hospital systems have moved away from doing it for a variety of reasons you understand well. So even I get stuck sometimes on am I trying to convince people to take them all to health and hospitals, or am I trying to convince them to, get the other hospitals to take them and their needs really to heart and focus on what do they need. We also have closer relations with the Department of Homeless Services. So that's another thing that, right, when someone comes to, say, Bellevue, right, we're on the phone with DHS and figuring out, do you have a safe haven bed? We think this person will go voluntarily. Can you send somebody over and have them actually walk them, right? So a lot of this, if you get the right case manager to walk the person to a safe haven bed, then suddenly it turns out the person will go voluntarily, even though they previously said, I'm not going to any shelter. So, it's a little bit of an issue to think about, do I want them all to come to us because we are the most culturally competent in the care of the seriously mentally ill who are homeless? We want to try to raise the competencies of all of the hospitals, have people go to whatever is the nearest hospital.
I do understand, and I know that the protocol, but I was just thinking for this particular case, since it's looking from kind of a policy, there is a financial implication, the cost of the ambulance, the cost of treatment, is there, like if they go to another hospital, is that being funded by, or the funding mechanism for that? That's, I guess.
Overwhelmingly, the seriously mentally ill have Medicaid. Okay. But the other hospitals will tell you that Medicaid in no way meets the expense. Mm-hmm. But because of that, there is no separate subsidy for the other hospitals. So, historically, the other hospitals have made their mental health smaller and smaller while they make things like cardiac surgery or cancer treatment bigger and bigger, because those things have margins where you actually make money relative to what it costs you, while the mental illness, there's also, as you would imagine, an issue of how hospitals want to be known, right? And there might be reasons certain hospitals would not want their middle class or upper class patients to be next to, because often our patients not have to be cleared in a medical emergency room, right? So they're going to ultimately go to psychiatry, but first someone needs to be sure that they don't have a medical illness, right? So some hospitals, I think, are not anxious to have these patients next to their other patients. Again, we view this as, our honor to take care of people. And that's who we are. But as you imagine, people make different choices.
Thank you.
Okay, so go ahead.
I had just a question and comment on a separate topic, but if we have a minute.
Sure.
Just ongoing work in collaboration with you all around respiratory viral season. We're really struggling to get our 65 plus folks, especially, vaccinated with the bivalent booster. I know you are too, but I'm curious if there's any pearls or suggestions. And similarly, all of our folks getting treatment for COVID is still a challenge, and providers are not as willing to prescribe Paxlovid as we would hope, and it's still a new medication. But, especially for our 65 plus folks getting treated for COVID, we're still seeing lots of challenges around that. So just curious, anything you want to share? Any
Michelle, just my full agreement with what you just said, and I don't know that I see an easy way around it. I've found acceptance, and this is more my own patients, acceptance of the flu vaccine right now much higher than of the bivalent.
Right.
I'm having a tremendous difficulty convincing people to take the bivalent.
Yeah.
There's almost, like a psychological, I'm done with COVID. I'm just done. I don't want to hear it. I don't want to talk about it. And I think around Paxlovid, there's still, the good thing is the system works great. I've heard only nice things about people who've called the virtual care. And I know people increasingly are able just to call their primary care doctors. So I haven't heard a single complaint about difficulty getting Paxlovid. But most people, in my experience, especially if they don't have serious symptoms, are not interested. Do you know, one of the questions people ask me that I wonder if you know, because I haven't been able to research it, is how important, if you start at minor symptoms, your day 0, day 1. I know Paxlovid is up to day 5. Day 1, the person says scratchy throat, little bit of cough, I don't feel bad. A lot of people say, I think I'll wait.
Right.
Is there reason to believe that they're hurting themselves by waiting to see whether or not it gets worse and choose it on day 4?
What we know is the earlier the better, especially what we're really concerned about is our 65 plus.
Sure.
And so when we look at the hospitalization rates for COVID, it's very much skewed, as you know, towards our elders. And so even folks who are 65, relatively healthy, and they have COVID and their symptoms are mild enough, they don't think they need it. We want the provider and the patient to be saying, no, I know I should get treated because I'm at risk of hospitalization. So the earlier the better, and 65 plus, it's just a no-brainer.
So I don't think the world feels that.
Yes.
That's the overwhelming, and I don't know whether it's as good as somebody who's knocking the door on 65. I don't know whether our use of 65 is also exactly right anymore.
Fair.
Or maybe we have to, we sort of use society 65 to mean your health is not as good. And as you know, 65-year-olds vary tremendously in their robustness, right? Less so 90-year-olds. Right. So, I think there are 65-year-olds who really feel that they are physiologically a middle-aged person. And they don't really, but I don't know that that's what the data should. I'm just relating what I think people feel.
Right.
Is that I'm a healthy 65-year-old.
Right.
I don't hear 90-year-olds saying as much, I'm a healthy 90-year-old.
So maybe we need T-shirts showing the hospitalization rates for 65
Well, but
plus, because it's very clear. It's a major drop off. But I hear you. This is our challenge.
Right. Yeah, I don't know if any board members have any answers that you want to offer on.
I have always been curious if Paxlovid, and this is from a very biased sample of myself when I took it.
Mhm.
Like I wasn't sick, so I wasn't like coughing. I didn't get my husband sick, even though we were in the same house together. So if there's another functionality, is like it makes you less likely to give it to other people, regardless. I don't know how true that is because haven't done any research on that. But in the back of my head, that is also
It'd be a compelling,
compelling research.
People are finding more compelling the argument on vaccination that it decreases the chance of long COVID. Not to say the data are strong, but the existing signal is that people who are vaccinated and get COVID seem to be less likely to get long COVID. And that does, right? So if you're talking to someone who says, look, if I get COVID, I'll get over it. And you look at them and you say, well, you're a healthy 45-year-old. If you get COVID, you will get over it. But your chance of having long COVID is higher. I've found that people do find that compelling. Okay, well, I get that. Yeah, I'll get over it. but, maybe I'll have longer symptoms. But so far, you can't say that about Paxlovid. We don't have any data to say that you're, more or less likely to have long COVID. That would be compelling. If you could tell people, look, you're going to be fine, but if you take the Paxlovid, you'll be less likely to get long COVID, I think you would move people. But you'd need data.
Problem too, which is that often than not, I mean, having had COVID, the first day you don't feel particularly bad. So it is very difficult to change your mind. By the second or third day, you start feeling much worse.
Right.
But it is hard to convince people that they should contact their primary care physician, that they should go on this whole regimen of Paxlovid. I think just the nature of COVID, not for everybody, I'm sure, but oftentimes there is just a day or two of very mild symptomology before it, becomes more aggressive. So.
That's why I was asking Michelle if she thought that the data suggested that it made a difference whether you took it on day 1 or day 3.
Right.
Because if it doesn't make a difference which day you take it, then maybe it's not so bad if you on day 1 don't want to take it, but day 3 you're like, I feel crummy, I'm going to start. On the other hand, she's right, all antivirals work best the earlier you start them. That's how they work, right? The more viral particles in your body, the harder it is for the antiviral to work. So I totally see the issue.
Yeah, it's tough.
Tough issue,
Okay.
Mr. Chair.
Yes. So let me move to the final section of our agenda. The committee and subsidiary reports were emailed to you and are in your folders for your review and submission into the record. Is there any old or new business to come before this committee? Hearing none, then the executive committee meeting is adjourned. Thank you so much. Happy holiday.